Okay, welcome to the first part of chapter 23. We're going to be dealing today with the respiratory system. Basically, the respiratory system evolved because of a need to deliver oxygen to cells in order to meet the demands for ATP. Life on the planet began as single-celled organisms in those early times. It was relatively easy for the organism to get fuel, excrete waste, and get oxygen as a result of simple diffusion. As organisms became more complicated in an adaptive response to their environment, we had a logistic problem, which is that we had tissues that were distantly removed from the source of the fuel and the source of the oxygen. And the result is that we had to figure out a delivery system in order to provide the cells the oxygen they need for ATP production. So the evolution of the cardiopulmonary system satisfied that need. Essentially, the circulatory system and the lungs work together to provide a way to deliver oxygen to tissues that are distantly removed from the anatomical features of the respiratory system directly. So what does the respiratory system do for us? Well, it provides ventilation. This is the simple movement of air into and out of the lungs. External respiration is essentially the gas exchange between the air in the lungs and in the blood. This happens subsequent to ventilation. And then we have transport of oxygen and carbon dioxide in the blood. The carbon dioxide, of course, is the waste gas, which is blown off when we expire. And when we breathe in, inspire, we take in oxygen, which is about 20% of the air we breathe, and we load that into the blood, and then that blood runs back to the heart through the pulmonary veins, and the heart will eventually pump that into the aorta. That oxygenated blood will then find its way to the rest of the body. Internal respiration is what happens once that oxygenated blood arrives at the tissues. The situation in the tissues, you have to remember, is very different from the situation in the lungs. In the tissues, we're constantly consuming oxygen and producing carbon dioxide. We're also generating a considerable amount of heat, and we're producing a more acid pH. And the reason for the acid pH is the production of carbon dioxide, which produces carbonic acid when it dissolves in water, but in addition to that, the production of organic acids also helps to lower the pH. And it turns out that those conditions are ideal to spur hemoglobin to unload oxygen and pick up carbon dioxide. By the time we exit the metabolically active tissue, the blood is, by comparison, relatively low in oxygen and high in CO2. The return trip back to the heart is affected by the venous return, and eventually that deoxygenated blood will find its way back to the lungs, where it will be reoxygenated, the carbon dioxide removed via diffusion and expiration, and the entire process will repeat. What else does the respiratory system do for us? Well, it regulates our blood pH by controlling our CO2 levels, and it also produces chemical mediators such as angiotensin converting enzyme, which of course has a dramatic effect on blood pressure as a potent vasoconstrictor. Angiotensin 2, which is the product of angiotensin converting enzyme, is involved in what we described in the chapter on the urinary system as the renin-angiotensin-aldosterone mechanism. It's also, of course, involved in voice production. Movement of air past the vocal cords allows us to produce sound and speech, and it is, of course, involved in olfaction. Molecules that dissolve in air are able to bind to olfactory receptors. That stimulus is relayed via the olfactory nerve back to the frontal lobe of the brain, where we experience the sensation of odor. It also provides protection against microbes by preventing entry and removing them from the respiratory surface. And if you look at the upper respiratory, you have some interesting safeguards with regard to the pseudostratified ciliated columnar epithelium and its mucus secretions. that trap particulates and keep them from entering the lungs, while the cilia on the apical end of these cells beats the particulate mucus up towards the mouth where it can be swallowed or spat out. In any case, it doesn't end up down in the lungs. The lungs are also populated by immune cells, macrophages and lymphocytes, which are on guard for any pathogens that do make it into the lungs. In the event that they do, they can be engulfed, chopped into little bits, presented to the immune mediators, the lymphocytes, and from that point we can generate now an army of B and T cells that will eventually go out and destroy the pathogen. You're looking here at the respiratory tract. The upper tract consists of the nose, the pharynx, and their associated structures, while the lower tract is the larynx, the trach, the bronchi, the lungs, and the tubing within the lungs. Okay, so you can see here the upper tract ends basically at the larynx. The lower tract runs from beneath the larynx all the way down into the lungs. Basically, the upper tract and a large proportion of the lower tract are nothing more than a pipe to get the oxygen down into the lungs. It isn't until we get to the alveolar, the ducts, the respiratory bronchioles, and the alveolar sacs that we actually affect gas exchange. And we call that the respiratory division of the respiratory system. The rest of it is called the conducting division because it's simply a way to get the air down into close contact with the blood. We start with the top of the upper respiratory. We begin with the nose. You're supposed to breathe through your nose. The external nose is made up of the nasal cavity that runs from the nares back to the conae. The vestibule is just inside the nares, and of course the hard palate helps to separate the oral from the nasal cavity, along with the soft palate, which is posterior to the hard palate. The nasal septum divides the nasal cavity into a right and left nostril. It's made of course, the superior aspect of the perpendicular plate of the ethmoid bone and the inferior aspect of the septum from the vomer. The conae are bony ridges on the lateral walls with meatuses between the openings. And this is designed to allow the air to swirl, to moisturize, and to filter before it ends up getting into the lungs. Openings to the paranasal sinuses and to the nasolacrimal duct are also found here. The nasolacrimal duct, of course, connects to the orbits, and the paranasal sinuses are openings from the nasal cavity to the bones that are essentially posterior to and peripheral to the nasal cavity, including the frontal bone, the maxilla, the ethmoid, the sphenoid, and we sometimes manage to get infections in these regions. Sinus infection is essentially an inflammation of the paranasal sinuses along with the nasal cavity. The pressure that's produced as a result of the inflammation of these hollow regions inside the bones is what produces the sensation of pressure behind the eyes when you have a sinus infection. What does the nasal cavity do? Well, it's a passageway for air. It cleans it, humidifies it, and warms it, so it preps it for entry into the lungs in order to reduce damage with the delicate tissue that lies there. It's also involved in olfaction, and along with the paranasal sinuses, it's a resonating chamber for speech. And if you don't believe me, hold your nose closed and talk, and notice the difference in the quality of your voice, as you can see. Okay, the pharynx is a common opening for the digestive and respiratory systems, and it has three regions. The nasopharynx behind the nose is lined with pseudostratified columnar epithelium populated with goblet cells that produce mucus and trap debris. It also contains the opening of the eustachian tube, which connects the middle ear to the pharynx. The floor is the soft palate. The uvula is the posterior extension of this. The oropharynx lines behind the mouth, and it's shared with the GI and lined with moist stratified squamous epithelium. And the laryngopharynx runs from behind the epiglottis down to the esophagus, and it's lined with moist stratified squamous epithelium as well. So one of the things you should do is ask yourself why this choice of material, right? Why stratified squamous epithelium in these regions? And the simple answer is to avoid mechanical damage, right? If it were a simple epithelium, then the likelihood of damage due to mechanical stress and strain would be much higher. So this is an excellent choice for this region of the respiratory. The larynx is shown here, and you're looking at an anterior, posterior, and lateral view. Most of the larynx is made up of cartilage, uh, and the rest is either fibrous or loose connective tissue, and you'll find a little bit of smooth muscle in here as well. The epiglottis is the lone purview of elastic cartilage in the larynx, and its job is to close over the glottis the opening to the trach when you swallow so that you don't get food and water into the respiratory. The hyoid bone, of course, sits superior to the thyroid cartilage and is anchored to it by the thyrohyoid ligaments. And then you can see below the thyroid cartilage the chrysoid cartilage and, of course, the tracheal rings. Their job primarily is to keep the upper airway open. Okay, so remember, this is connective tissue whose primary job is to serve as structural support. You can see on the back of the larynx that these rings don't go all the way around. They terminate, forming a C-shaped pattern below the chrysoid, and the purpose is to accommodate the esophagus when you swallow. This area is also spanned by a muscle called the trachealis muscle, which can control the diameter of the larynx as well. You can see here from the side other features: the epiglottis, the thyroid and chrysoid cartilages, and also the tracheal rings. You can also pick up the hyoid bone. In men, remember that on the thyroid cartilage there's usually an anterior prominence called the Adam's apple. This is generally absent in women. Basically, this is a passageway into the lower respiratory. Okay, the job here again is to trap particulates and to further humidify and warm the air and filter it so that we can get it into the lungs with a minimum of damage. Very little gas exchange happens in these regions at all. Some unpaired cartilages that we should point out: the thyroid cartilage is the largest and contains the Adam's apple. The chrysoid is underneath it and it forms the base of the larynx. The epiglottis, of course, the flap of elastic cartilage that covers the glottis when you swallow. There are some paired cartilages as well. The arytenoids, the corniculates, and the cuneiforms are essentially designed to change the tension in the vocal cords when you speak. The arytenoids are attached to the chrysoid like a pair of little horns. The corniculates are attached to the arytenoids, and the cuneiforms are contained in the mucous membrane. And if we look back at the larynx just a minute, you can see these guys back here. You can pick up the arytenoids and the corniculates up here. When they pivot, what happens is we change the tension on the vocal cords, and that's what allows us to speak in different tones and pitches. Okay? Ligaments that extend from the arytenoids to the thyroid include the vestibular folds, also called the false vocal cords, and of course the true vocal cords, known as the vocal folds, that generate sound as air passes through them. They basically border the glottis. Okay, so when air rushes past these pieces of connective tissue, they vibrate, and that's what produces sound. What is the larynx for? Well, it maintains a passageway for air movement. The thyroid and the chrysoid cartilages help keep it open. The epiglottis and vestibular folds prevent water and food from getting into the larynx. The vocal folds are the source of sound production. A greater amplitude of vibration produces a louder sound, and a greater frequency of vibration produces a higher pitch. The arytenoid cartilage and skeletal muscle that's attached to them determine the length of the vocal folds and also abduct the folds when you're not speaking to pull them out of the way and make the glottis bigger. The pseudostratified ciliated columnar epithelium traps debris in the upper airway and prevents its entry into the lower respiratory. And here you can see the vocal folds. Okay, you can pick up here the base of the tongue. You can see the true vocal cords, the vestibular folds. There, of course, is the epiglottis, and then back here you can see the cuneiforms, the corniculates. You can't really see the arytenoids because they're going to be inferior here. And this is what a doctor would see if he were to look down your throat with a laryngoscope. Okay, this is actual laryngoscope picture. And here you can see the larynx without the connective, the soft tissue has been removed. You're basically just looking at the support structure, so you can pick up the cartilage and the bone, and you can also see the vocal cords, again, attached to the arytenoids, and as they pivot, that's what produces the change in the pitch of our voice when we speak. Okay. Okay, your trach is a membranous tube of dense, regular connective tissue and smooth muscle, supported by about 20 hyaline cartilage C-shaped rings, of course, that are open in the back to make room for the esophagus as you swallow food or water. The posterior surface is elastic ligaments, membrane, and bundles of smooth muscle called the trachealis, which will contract during coughing. Inner lining is pseudostratified ciliated columnar epithelium with goblet cells. The mucus is there, of course, to trap debris. The cilia are there to push the debris-laden mucus up towards the mouth so we can either expectorate it or we can swallow it. At any rate, it doesn't end up down in the lungs. It divides to form the right and left pulmonary bronchi at the carina, where the cartilage bifurcates. The membrane of the carina is sensitive to irritation and inhaled objects, and this is one of the things that initiates the cough reflex. What you're looking at here is just a transverse section through the trach. You can see, again, a variety of different tissues making up the organ. There's the esophagus posterior to the lumen of the trach. You can pick up now the hyaline cartilage that holds it open. And you can also see, of course, the mucous membrane lined, of course, on the area that is in contact with the lumen with pseudostratified ciliated columnar epithelia that, of course, produces the mucus. You can also see smooth muscle here where the C-shaped rings terminate. That's the trachealis. And you can also pick up connective tissue, of course, anchoring the organ to the surrounding structures. And if we were to take a longitudinal section through the lining of the trach, what we would see again is the pseudostratified ciliated columnar epithelium, the goblet cells that produce the mucus, and notice the direction of the mucus flow. One of the things that happens in individuals that smoke is due to the inhalation of carbon monoxide, you can paralyze these cilia. The result is that the particulate-laden mucus ends up down in the lungs, where it produces irritation, inflammation, and scarring, often generating irreversible damage. That, along with the tar that coats the lungs, reduces the ability of those organs to load oxygen into the blood and cuts down on the efficiency of ventilation. Because, again, basically what are we doing? We're taking away surface area that's so valuable in allowing gas exchange. Remember also, while we're on the topic, that the gas exchange is primarily driven by the difference in the gradients of carbon dioxide and oxygen in the air and in the blood. The blood that's coming to the lungs from the heart is relatively low in CO2, or relatively high in CO2 and relatively low in oxygen, the result being that the CO2 tends to diffuse out of the blood at the same time that oxygen tends to diffuse in from the air that we inhale, right, which is about 20% oxygen. The lungs are perfect for this activity because the gas exchange regions, the alveoli, are simple squamous epithelia with a basal lamina lined superficially by clusters of capillaries. And so the gas doesn't have very far to travel to get from the air that you inhale into the bloodstream, and of course from there return to the heart and be pumped throughout the entire body. The trachea and the terminal bronchioles, which are ciliated for the removal of debris, comprise the tracheobronchial tree. The trachea divides into two primary bronchi, which in turn split into secondary bronchi, one for each lobe. So the left lung has two, the right lung has three. Bronchopulmonary segments are defined by the tertiary bronchi, which subdivide into smaller bronchi. then to bronchioles, and then finally into terminal bronchioles. Cartilage holds the whole system open, and smooth muscle can control the diameter. And the activity of smooth muscle we term bronchoconstriction or bronchodilation. And this helps to route the air in the lungs so that it comes into contact with the blood most effectively. And smooth muscle activity in pulmonary tissues is opposite what we see in systemic tissues. Basically, the purpose being to try and get the most perfused tissue to match up with the most well ventilated tissue, and the result then is optimal diffusion of oxygen into the blood and CO2 out. As the tube becomes smaller, the amount of cartilage decreases and the amount of smooth muscle increases. By the time we leave the terminal bronchioles, we enter the respiratory zone, and this is where gas exchange happens in earnest. The respiratory zone is defined at its beginning by the respiratory bronchioles that branch to form terminal bronchioles, branch from the terminal bronchioles rather. The respiratory bronchioles have some alveoli, but they eventually empty into alveolar ducts, which dump into the alveolar sacs, and this is where the lion's share of the gas exchange actually occurs. There's no cilia, but debris is removed by macrophages that patrol the area and move into nearby lymphatics or into the terminal bronchioles. So again, we put our lymphatic tissue where it's likely to do the most good. The respiratory membrane is made up of three components. Type 1 pneumocytes are squamous epithelial cells that make up 90% of the surface area of the alveolus and they're for gas exchange. The type 2 pneumocytes are cuboidal-shaped secretory cells that make surfactant, which is a detergent that allows the lungs to very easily expand and contract when you breathe by overcoming the attraction of water in the lungs for itself. Okay, so basically breaks surface tension. Dust cells are the phagocytes that patrol the lungs, removing, of course, debris and pathogens. Layers of the respiratory membrane include the thin layer of fluid that lines the alveolus, the alveolar epithelium, the basement membrane of the alveolar epithelium, and then the interstitial space, and the basement membrane of the capillary endothelium, and then the capillary endothelium itself. But while that sounds like a lot of layers, it's very little distance. The idea here is that we want to facilitate diffusion, and so the amount of thickness of those membranes is always kept to a minimum. The tissue surrounding the alveoli contains elastic fibers that allow it to recoil. One of the things we have to appreciate about this delicate membrane is that it's very good at its job, which is exchanging gases. Anything that's going to thicken this membrane is going to be a problem. The accumulation of water is going to impede gas exchange, as will the introduction of particulates and tar, and also the production of infected mucus, as we see, for instance, in individuals that have cystic fibrosis. Other things that will interfere with gas exchange include the scarring of the lungs, which can occur as a result of exposure to particulates. Scar tissue, of course, is thicker than epithelial tissue, and the result, of course, is an impedance of gas exchange. And again, this is something that we see in a lot of diseases. We see this, for instance, in cystic fibrosis. We see it in emphysema. We see it in a condition called sarcoidosis. The bottom line, you thicken that tissue, you impede gas exchange, and in addition to that, you also reduce the elasticity of the lungs, and that is also going to impede ventilation. The lungs are paired organs of respiration. The base sits on top of the diaphragm, and the apex is at the top near the clavicle. The hilus is on the medial surface, and this is where the bronchi, blood vessels, lymphatics, and nerves enter. All the structures in the hilus are known as the lung root. The right lung has, of course, 3 lobes separated by fissures. The left lung, 2 lobes separated by fissures, and we also feature a cardiac notch to make space for the heart. There are different divisions. The lobes are supplied by the secondary bronchi, and the bronchopulmonary segments are supplied by tertiary bronchi and separated from one another by connective tissue. Lobules are supplied by bronchioles and separated by incomplete partitions. And what you're looking at here is simply a comparison of the right and left lungs, right? Left lung here, right lung over here. And what you can see are the different lung segments. I'm not so concerned with you knowing where the lung segments are as the fact that you have different numbers of lobes in the right and the left lung. The right lung does the majority of the ventilation. When you breathe, the left lung is basically there to help out. Notice up top also you can see the root of the lung, the hilus here, where the blood vessels, the lymphatics, and the nerves enter and exit the organ. Lung tissue is amazing. You'll see in lab that if you didn't know better, you would think that preserved lung tissue was nothing more than styrofoam. It has about that consistency. Um, Obviously, it has a lot of surface area in order to increase gas exchange. Um, and it's relatively lightweight as well. You're going to actually inflate a lung in lab, and you'll see the dramatic change in volume that results when you pump air into the organ. Okay, what you're looking at here are just the muscles that are involved in respiration. The end of expiration is shown on the left, the end of inspiration is shown on the right. And if we start with the end of expiration, you can see the involved muscles include the sternocleidomastoid, the scalenes, the external intercostals, the pec minor, and in an indirect way, the diaphragm. Basically, when you're expiring, what's happening is the diaphragm is relaxing. We should note that in forced expiration, the abdominal muscles are contracting and forcing the internal organs up against the diaphragm. And at the same time, what's happening is that the muscles that would normally um, elevate and expand the rib cage are relaxing. The external intercostals help to pull the rib cage down and in. This produces a positive pressure around the lungs, and if the nose or the mouth are open, what will happen is that the air will be forced out. Basically, there's an inverse relationship between volume and pressure. As the volume of a closed container decreases, the pressure increases. As the volume of a closed container increases, the pressure decreases. And that's basically the mechanics of what we call negative pressure breathing. On the right, you can see the muscles involved in inspiration. And what you're observing here is a contraction of the diaphragm causing it to flatten. At the same time, if we're imagining now forced inspiration, the pec minor and the intercostals will allow along with the sternocleidomastoid and the scalenes, allow the chest cage to thrust forward and expand outward. This produces a negative pressure around the lungs, which will cling to the thoracic cavity, the pleural cavities inside which they're housed, and that produces vacuum in the lungs themselves. And if your nose and mouth are open, then what will happen is that air will, of course, move from an area of high to low pressure into the lungs, and that will affect ventilation. Okay? The nerve that's responsible for talking to the diaphragm, which is the main muscle of breathing, is the phrenic nerve. Remember that there are cervical spinal nerves that talk to the phrenic nerve. They are cervical 3, 4, and 5. Remember that rhyme from A&P 1, C, 3, 4, 5, keep the diaphragm alive. If we clip any one of those nerves, the phrenic nerve won't operate, and the diaphragm will cease to be functional, and the result is that you'll have to be put on a ventilator. Okay, let's talk a little bit about the thoracic wall. The thoracic vertebrae, the ribs and the costal cartilage and the sternum and associated muscles make up the wall. The cavity is a space that's enclosed by the thoracic wall and diaphragm, which separates the thoracic from the abdominal cavity. We have to appreciate the fact that the thoracic cavity is a closed gas-filled chamber, and hopefully it stays that way throughout your entire life, because if you were to perforate that chamber, then air would rush into it and your lungs would collapse in a condition known as pneumothorax. Inspiration and expiration involve the diaphragm, the external intercostals, the pec minor, the scalenes. The diaphragm is, of course, the dome-shaped muscle at the base of both lungs that lies on top of the liver and the stomach and the spleen, okay, and beneath the heart. It has a central tendon at the top of the dome, In quiet inspiration, it accounts for about 2/3 of the increase in the size of the thoracic volume. Inferior movement of the central tendon and the flattening of the dome causes the abdominal muscles to relax in concert with the flattening of the diaphragm. And what happens now is that creates a negative pressure around the lungs, and the air will go from an area of high to low pressure, and that's the ventilation. Other muscles will elevate the ribs and the costal cartilages and allow the lateral ribs to move. Expiration involves muscles that depress the ribs and the sternum. These include the abdominal muscles and the internal intercostals. In quiet expiration, we have relaxation of the diaphragm and external intercostals with contraction of the abdominal muscles. In labored breathing, all inspiratory muscles are active and contract more forcefully, and the expiration is more rapid as well. What you're looking at here is the effect of the ribs and the sternum on the dimensions of the rib cage. You can see here how the articulation of the ribs with the sternum allows a bit of a swinging motion at this amphiarthrotic joint. The result is that as we thrust forward and upward, we elevate and expand the rib cage, causes the thoracic cavity to increase in volume, and that, of course, is going to promote greater ventilation. The pleural membranes line the lungs and the thoracic cavity and produce a lubricating fluid that allow the lungs to easily slide over their surfaces when you breathe. This is called pleural fluid. The visceral pleura attach to the lungs themselves, made up of simple squamous epithelia secreting serous fluid, while the parietal pleura attach to the internal thoracic wall. The pleural fluid acts as a lubricant and helps hold the two membranes close together. The mediastinum, of course, is the central region, and it contains the contents of the thoracic cavity except for the lungs. So here we would see the heart, the esophagus, the trach, the great vessels, and so on. There's two sources of blood to the lungs. The pulmonary artery brings deoxygenated blood to the lungs from the heart to be oxygenated in the capillary beds that surround the alveoli. The blood leaves the pulmonary veins and returns to the left side of the heart. Oxygenated blood travels to the tissues of the bronchi via the bronchial arteries, which are branches of the thoracic aorta, to the capillaries. Part of this now deoxygenated blood exits through the bronchial veins to the azygos, and this part merges with blood of the alveolar capillaries and returns to the left side of the heart. Blood going to the left side of the heart via the pulmonary veins carries primarily oxygenated blood, but also some deoxygenated blood from the supply of the walls of the conducting and the respiratory zone. And there's two lymphatic supplies, the superficial and deep lymphatic vessels that exit from the hilus. The superficial drain the superficial lung tissue and the visceral pleura, and the deep drain the bronchi and the associated connective tissue. There are no lymphatics draining the alveoli. So, take-home lesson there is that the lung tissue itself, the lungs as organs, actually get their oxygenated blood from the systemic circulation. The pulmonary circuit is designed to do one thing, which is to load oxygen into the deoxygenated blood that's coming to the lungs from the heart, from the right side of the heart, and then return it to the heart so it can be pumped to the entire body. Okay, ventilation is just simply the movement of air into and out of the lungs. Air moves from an area of high to low pressure, as does a liquid. Boyle's law is essentially a relationship that states that pressure is equal to a constant divided by the volume at a given temperature. If barometric pressure is greater than alveolar pressure, then air will flow into the alveoli. If the diaphragm contracts, then the size of the alveoli increases. Remember that P is inversely proportional to V, so as V gets larger when the diaphragm contracts, then the pressure in the alveoli gets smaller. Now, one of the things that I always like to touch on when we start talking about gas laws is essentially this idea that there's one law really that encompasses all the relationships you're going to see, Charles' law, Boyle's law, and so on. And it's a really easy to remember overall law, and it's called the perfect gas law. Okay, and the perfect gas law is simple as all get out. Basically, we can write the perfect gas law as such. Perfect gas law states that PV is equal to nRT. Okay, where P is pressure. Okay, so pressure. V is volume. N is the number of moles of gas. R is a gas constant. Okay. And T is the temperature in degrees Kelvin. That's the perfect gas law, and it covers all these other laws that you're going to see here. The units for R, the way I always remember them, were it's in liter atmospheres per moles degree Kelvin. Okay, and those are quantities. Okay, and how do you get that? Well, you find if you rearrange the law to solve for R, you can come up with this, right? If we rearrange this expression, R is going to equal PV over NT, right? And that's how you get the units for R. And this will apply to changes in volume, changes in pressure, changes in temperature, and changes in the number of moles of gas. So let's take a listen to alveolar pressure changes when you inhale and exhale.
At the end of expiration, barometric air pressure and alveolar air pressure are equal. Therefore, no movement of air into or out of the lungs takes place. Inspiration begins with contraction of inspiratory muscles to increase thoracic volume. This results in expansion of the lungs and an increase in alveolar volume. The increased alveolar volume causes a decrease in alveolar pressure below barometric air pressure, and air flows into the lungs. At the end of inspiration, the thorax and alveoli stop expanding. Airflow into the lungs causes alveolar pressure to become equal to barometric air pressure. Because the pressures become equal, no more movement of air occurs. During expiration, the volume of the thorax decreases as the diaphragm relaxes and the thorax and lungs recoil. This results in a decrease in alveolar volume and an increase in alveolar pressure. Since the alveolar pressure is now greater than barometric air pressure, air flows out of the lungs. Air continues to flow out of the lungs until alveolar pressure becomes equal to barometric pressure.
Okay, so let's address changing alveolar volume. Lung recoil causes the alveoli to collapse, and this results from elastic recoil, where elastic fibers in the alveolar walls eventually recoil, and then surface tension, which is just the attraction of the water that lines the inside of the lungs for itself. Okay, the water interfaces with air, and the polar molecules have a great attraction for each other, and they tend to pull inward onto the other water molecules, and this tends to make the alveoli collapse. Surfactant is there to overcome this. If we didn't have surfactant around, every time you exhaled, your lungs would completely collapse and you wouldn't be able to reinflate them. The type 2 pneumocytes are what produce this surfactant. Respiratory distress syndrome is common in infants that don't make enough surfactant because their respiratory system really hasn't fully developed yet. And what we have to do is give them surfactant in order to allow them to breathe. And while we're on the topic of surfactant, there's another disease that has an extremely detrimental effect on the respiratory system, and that's a condition known as CF, cystic fibrosis. Okay, and what happens in CF is that the surfactant is too salty, so it has too high of a sodium chloride content. The result is that it increases its viscosity, becomes difficult to clear, and it also gets populated by pathogens. Bacteria start to grow in it, and as the bacteria grow and die, they release DNA. The DNA causes a further increase in viscosity, and this becomes a nightmare because it gets very difficult for you to get a good breath of air because the lungs are basically coated in glop. So what do we do about this problem? Well, if you're a newborn, somebody can hold you upside down and percuss you on the back until you clear all of this mucus, and then you can breathe for another day. Problem is, by the time you grow up, there's nobody going to do that for you. So we've come up with a device called an AmbiVest. It's a partial solution to this problem, AmbiVest. And what the AmbiVest does is it plugs into a power supply and it wraps around you like a life jacket, and it percusses rapidly and allows you to basically expectorate this mucus so that you can continue to breathe. We use this in conjunction with inhalers that break apart the DNA and reduce the viscosity of the mucus so that you can clear the lungs and manage to continue to breathe. Problem with this disease is it's a genetic disorder. We can actually pick this up now in amniocentesis. It's a deletion of a pump that's in every cell in the body, and we can prepare the parents for life with the disease. The deletion was actually characterized at Children's Hospital Cincinnati under the aegis of the Esiason Foundation. Boomer Esiason had a son who had the condition, Gunnar, and he donated money to Children's for the CF Foundation, and a lot of the groundbreaking research has come as a result of this relationship. Pleural pressure is essentially negative pressure that can let the alveoli expand. When the pleural pressure is low enough to overcome lung recoil, they can open up, they can increase in volume. Pneumothorax is an opening between the pleural cavity and the air that causes a loss of pleural pressure, causes the lungs to collapse. Normal breathing cycle shown here. If we start at the first diagram here, what we see is pleural pressure decreasing as the thoracic volume goes up. Just remember the perfect gas law, okay? So what's happening here, thoracic volume's increasing, pressure's going down. The diaphragm is flattening. Next thing that happens as inspiration begins, the intraalveolar pressure decreases below barometric, and because the decreased pleural pressure causes alveolar volume to increase, by the end of inspiration, intraalveolar and barometric pressure are equal. Okay, so you can see that we're creating essentially a vacuum around the alveoli that's going to pull air in from the outside, as long as your nose and mouth are open. Next part, during inspiration, air flows into the lungs because intraalveolar pressure is lower than barometric, and as pleural pressure increases, when we breathe out, right, we start to force air out of the lungs. As expiration begins, intraalveolar pressure increases above barometric air pressure. Because the increased pleural pressure causes alveolar volume to drop, by the end of expiration, intraalveolar and barometric pressure are equal. Okay, so you can see as the air leaves, okay, by the end of expiration, the two pressures have equalized. During expiration, air flows out of the lungs because intraalveolar pressure is greater than barometric air pressure. Okay, so what you're looking at in each of these three graphs is the pleural pressure top side, the intraalveolar pressure in the middle, and the change in the lung volume. Okay, so let's start with the two that are easiest to understand, right? Let's look at the pleural pressure, right? So as you begin to breathe in, the diaphragm begins to flatten, okay? The chest cavity begins to expand with the help of the other muscles of breathing, and the pleural pressure begins to drop, okay? Thoracic volume's going up. At the same time, okay, the change in the lung volume is going up, right? So as the change in the pressure drops, the change in the volume increases, okay? Fairly straightforward relationship. You could think of this almost like a closed container with a piston that moves up and down, okay? In this case, the piston is moving down and increasing the volume of the container, and at the same time the pressure is beginning to drop. Okay? Then on the flip side, as we breathe out, what happens? The pleural pressure begins to increase at the same time that the lung volume begins to decrease. Think of that piston now is beginning to push on the gas inside the chamber. Obviously the pressure will begin to rise. All right? And all you're looking at here is the change in the intra-alveolar pressure. Okay, so you can see here that as the pleural pressure drops, the intra-alveolar pressure will also drop. Okay, and the point here is to obviously ventilate the tissues of the lungs, right? That vacuum is pulling the air in. And then what will happen is it will eventually equalize, all right, after we've inspired. We're going to be at barometric pressure again, and then as we begin to breathe out, what happens? Well, the pleural pressure drops, okay, and the pleural volume the pleural pressure is going to begin to rise, the pleural volume is going to begin to drop, and at the same time, this is going to produce a positive pressure in the alveoli, and this is going to force the air out of the lungs, okay? By the time we're done, all the air is exited, and then we repeat the entire process after the barometric pressures equalize once again, okay? So, fairly straightforward concept, okay? The change in the volume and the change in the pressure, again, inversely related. Compliance is the measure of the ease with which the lungs stretch and contract. The greater the compliance, the easier it is for a change in pressure to cause expansion. A lower than normal compliance means that the lungs and thorax are harder to expand. Conditions that decrease compliance include pulmonary fibrosis, which is basically scar tissue in the lungs, pulmonary edema, which is fluid in the lungs, and respiratory distress, which could be the result of lack of surfactant. Okay, and so what happens is that surface tension phenomena comes in and the lungs begin to close in on themselves. Also, increased resistance to airflow caused by obstruction, as seen in asthma, bronchitis, or in lung cancer. What you're talking about here essentially is cutting down on wind speed, right? Because you're choking down on the pipe for some reason or another. Also, deformities of the thoracic wall, such as kyphosis or scoliosis, can play a role. Okay. One of the things we should point out while we're sort of dealing with this is this idea that that problems with respiratory conditions can be grouped into two classes, right? There's obstructive diseases, and there's restrictive diseases, and some diseases are both. Okay, restrictive, T-I-V-E there. Okay, obstructive disease basically just means that we're cutting down on your wind speed somehow. Okay, so there's something that's keeping you from getting the air into the lungs as quickly as you would like. Okay, eventually the lungs will fill, okay, but not as quickly as it would be in a healthy individual. In obstructive pulmonary diseases, what we tend to see, if they're strictly obstructive, is no change in vital capacity, but a big change in what we call minute respiratory volume. Restrictive disease is different. In restrictive disease, what happens is that the lungs can't expand the way they would like to. And this can be due to the lack of elasticity in the lung tissue, could be due to problems with the dimensions of the thoracic cage. Um, and there are diseases that kind of cross both, okay, that are both obstructive and restrictive. An example of a restrictive disorder would be these guys right here, right? Kyphosis and scoliosis that change the dimensions of the thoracic cavity would be essentially restrictive disorders. In a restrictive disorder, you're going to see a reduction in vital capacity, but not that much of a change in wind speed. These guys up here, okay, asthma would be essentially an obstructive, okay. Bronchitis is going to be obstructive, but if it's like chronic and results in scar tissue, it could potentially also be restrictive, okay. As you reduce the elasticity of the lungs, that would qualify as a restrictive disorder. Lung cancer, okay, could be both, right? You could have both an obstruction. You could also have restriction if the tumor mass was to impede the ability of the lungs to expand, let's say, all right, then we could kind of say that could be both an obstructive and a restrictive disorder. Depends on where the oncogenic tissue is located. Okay, so some of these diseases are purely one or the other. Some of these can kind of live in both camps. So obstructive and restrictive. Spirometry just measures the volumes of air that move into and out of the respiratory. The spirometer is the device used. You'll use one in lab, and we'll take some different respiratory volumes to assess your ventilation efficiency. Your tidal volume is the amount of air inspired or expired with each breath. At rest, that's about half a liter. Your inspiratory reserve is the amount that can be inspired forcefully after inspiration of the tidal volume. It's about 3 liters at rest. And the expiratory reserve is the amount that can be forcefully expired after expiration of the tidal volume, and it's about 100 milliliters at rest, while your residual is the volume still remaining in the respiratory passages in the lungs after a forceful expiration. It's about 1.2 liters. There's also some other capacities we should note. Okay, your inspiratory capacity is your tidal plus your inspiratory reserve. Your functional residual is your expiratory reserve and your residual. And your vital capacity is the sum of your inspiratory, your tidal, and your expiratory reserve volume, while your total lung capacity is your VC plus your residual. We'll start off our next talk with a demonstration of each of these capacities. You'll get to watch me breathe in class. For right now, if you want to Google spirometry or look up your respiratory lab, you'll get a pretty complete explanation for how each of these volumes are determined. Okay, I'll see everybody in class.